Essentials of Health Information Management, Principles and Practices, 2nd edition, Chapter 5, Electronic Health Records. Our presentation today is looking specifically at electronic health records. A lot of things we've talked about in past presentations were directed toward paper records. It does form the basis for a lot of the practices that you see going on in the healthcare environment, and some of those practices will still remain even with the advent of the electronic health records. So this presentation is more or less looking at their electronic health records. We know that the paper environment is slowly being transformed to a virtual electronic world, and this is where the electronic health record actually fits in. And as I mentioned, there is an evolution. Things are changing, and actually what we call automated records, their name also changes. The terms we use to represent automated records change, and that's due to the evolution of their functions and the environment in which they are in. When you look at your Chapter 5 in your textbook, it talks about a couple of terms there in terms of automated records. One being the computerized medical record. That was a term that was used mostly during the period of 1970 to 1980. This is when those early attempts arose during that time period, and you mostly saw those records used for administrative type purposes like patient registration or the insurance side of things. You also saw these type of records mostly in a university type setting. Then throughout the 1980s, they envisioned a electronic record system, and so therefore in 1991, the Institute of Medicine, they had coined the term computer-based patient record. That's when that came on the scene. A computer-based patient record, or CPR, which gave a broader scope to the functionality of an automated record. They really were looking at having or envisioning what we call a longitudinal patient record, where they have records from different episodes of care, different providers and facilities, and they all are linked together to where you can have a view over time of that patient and their treatment. So they really wanted to link patients' information across different locations using what we call a unique identifier. They wanted to have, they talked about functions like alerts and reminders in the record, in that computer-based patient record. They looked at, according to that Institute of Medicine's report in 1991, some of the things that the electronic record should help was the physician's access to that patient's information, a computerized order entry system, decision support systems, secure electronic communication, patient access to their information, computerized processes, standard-based electronic data storage, and reporting mechanisms. You also saw these automated systems merging with things like dictation and transcription software, document imaging software. They're bringing all this stuff together. Now, also around the late 1990s, they're in their evolution of what we thought about, or what we described as a automated record. So we went from a computerized medical record to a computer-based medical record, and then around that late 1990s, we start using the term electronic medical record. merging data from different data systems into one centralized database that we call a clinical data repository. At that point, they were using the CPR, the computerized patient record, and the electronic medical record terminology interchangeably. You saw, most of the time, you saw your records in an outpatient setting, and you also had those electronic medical records in an inpatient setting, but you really rarely saw them interact with one another. Then in 2003, your Institute of Medicine coined the term electronic health record. This is what we more or less use today, because electronic health record is a more globalized term, kind of records across different continuums or different areas of care, whereas we tend to use now the electronic medical record in one specific facility. So electronic health record is really the going term that we are using at this point. We also had some things going on the political scene, the governmental scene, in terms of support for electronic health record systems and different technologies to help in sharing of information and interoperability. We're going to talk a little bit about those a little later on, but some of those things, like the establishment of the position of National Coordinator for Health Information Technology. They're trying to aid in sharing that information to help reduce medical errors. You also had the enactment of the American Recovery and Reinvestment Act, which helped, it brought in stimulus, and I think I got a slide a little further along that talks a little bit more about that as well. But these are some of the things that have brought about the evolution we see in electronic records, as well as our transition from a paper environment into a electronic environment. The other thing we can look at, if you refer in your textbook to Table 5.1 on page 109, there are advantages and disadvantages to having manual systems versus automated systems. We're on manual systems for the majority of people, our different facilities, but increasingly we're seeing a lot of automation. One thing about manual systems, in terms of advantages, they have low startup costs. It's very easy to train staff on manual systems, right? Other things you can look at in terms of that, on the flip side of that, because you got advantages, on the flip side there are disadvantages. The illegibility of the handwriting, we know that's a big issue, and I've mentioned this before with physicians. It's difficult to abstract information, meaning pulling certain information that we need for certain tasks and processes. When you have paper records, you got to dig through what have you, which is different than in an automated system. A lot of things maybe that is wrong or errors in those records are they're not usually discovered until we do that discharge analysis that we talked about when we were looking at assembly and analysis. On the flip side, with your automated records, again, it's coming from Table 5.1. When we bring in that automation, it improves access to that patient information, because you can have multiple users at the same time in different places using that same information. We don't need to use a lot of space, physical space, so it doesn't take up a lot of that as your paper records do. We kind of get rid of the legibility problem that we are having in terms of when you have an automated system. And we can capture data what we call point of care. So timely capture, quicker than you can if you're documenting it paper-wise. You can customize your views. I mentioned that before when we talked about paper records in the different formats, like the source-oriented and problem-oriented. In an automated record, you can see your information in any manner you wish. Enhanced security, reduction in administrative costs, all of these things are advantages to automated systems. Now, in terms of disadvantages, because it's more expensive to implement. but you probably you will see savings in the long run, but initially it's going to be expensive. Staff has to be trained because there's technology and stuff like that involved, so it can be expensive. You got to maintain those systems. Also, you got the change management that you have to implement because a lot of people are resistant to change. So those are some of the things that you have to look at in terms of advantages and disadvantages to both types of systems. One thing you need to remember that the electronic record is not here to totally obliterate or get rid of paper records. It's here to enhance and make processes more effective. So there are situations in which paper will be best, or it's not saying we won't ever use any more paper and everybody's just solely electronic. That's not the idea here. We are looking for improvement though. So what you see here in our environment is that people are in a state of transition. A lot of times you will see facilities where they have what we call hybrid records. And basically a hybrid record is one that is part paper and part electronic. All right? So that means that that facility is in a transitional state. A lot of times you see in a hybrid record when they're trying to move to fully electronic records. Some of their paper documents, when you have that, they end up scanning those documents in through a document imaging system so that we can now have it on an electronic device. And a lot of times what you're going to see when they have that process or that task, that they have to do what we call prep the documents or prep the paper. All this means is before they send it into that scanner, that they got to take out any paper clips, staples, fasteners, or anything like that that's on the paper. They also are going to check to make sure that the patient's name and medical record number and all that pertinent information is labeled on that document. If the pages have any tears or creases and stuff, they're going to straighten that out, repair all the tears, and then if there are tears, they make copies of that so that, and basically they're doing all that because when you send it into a scanning machine, it's sort of similar to when you are making copies on a copier machine. If you have staples and stuff, they get caught up in there, and that doesn't work out well. So this is what we mean by prepping the document, similar to when you're prepping documents to run it through a copier. Okay, and so those documents can appear on a document imaging system. Then a lot of times when they're doing that, they index those. And what we mean by indexing is that they are organize them according to identification numbers, and those identification numbers are unique to each patient. So more likely that's going to be your medical record number. Because they index it, that means all the records do not have to be, all the patient's record does not have to be scanned at the exact same time. So maybe you do a bulk of the record at one point, then they have some other documents that come in that belong to that record. When they index it, they can scan those in at any time, and you can pull all those together upon once needed. They also do quality checks for things like that. So someone has to go in there and make sure that that information scanned properly is readable before they can get rid of the actual paper record. Another thing that's interesting here in terms of when you have what we call those hybrid records, your facility needs to have some type of way to determine what documents are kept in an electronic format and what documents are kept in a paper format. If you look at page 111, figure 5.2, this is an example of a record transitional template. So basically all it is telling you what type of document it is, what location, and what format is in. So the basic premise of this is which document in your record is an electronic piece, and which document is kept as paper because you got a hybrid record. right. Another thing that's of interest here is what we call regional health information organization. And basically, what this is like an electronic network of patient medical information gathered from multiple healthcare organizations in a geographic region. They also have national health information networks, which is on a national level. But with your RHIOs, what they are trying to do is you have different facilities, no matter if they're competitors or not, but they all are going to agree to join one another and share patient information. So they store all this information on this electronic network. So if, say, the hospital over here, they load their information, it flows into that. The physician office over here, or the specialist over here, and they all share the information. The insurance company, everybody gets on, and it's like it's an electronic network where they collaborate with one another. And they share that information. It's health information exchange is what's going on here, HIE. You'll hear that term quite often, health information exchange. So they have access to multiple types of patient information. This will help improve the quality of patient care. So where that patient goes, everyone has, all the providers has access to their information on this network. All right? And so they have those in which they do that in regions, and then they have a national one, and this is a vision. They still have some challenges to some of these. We have one here called Big Bend, RHIO, Big Bend Rio, right? They have some challenges and everything, but they still working through those, and so it's a collaborative effort in which they are trying to improve on information access for providers, which will ultimately improve the quality of patient care. So there's different stakeholders in RHIO, basically people who have a horse in this race or can benefit from a regional health information organization. So your hospital, it can help decrease the medical errors because now you are privy to all the information about that patient. And also administrative costs are reduced because you're not necessarily trying to call different facilities, maybe that patient's primary care or some other place to try to gather information. Is all in one place. Physicians, of course, same sort of reasons. They can benefit patients as well because they're going to get better quality care, coordination of care, patient safety is going to be improved. Health plans and insurers, they are also considered stakeholders and can benefit. Say, for instance, when all the information is available to your providers, they don't have to pay for duplicative tests that a provider may run, so to reduce costs to them. And your public governmental health agencies are also considered stakeholders in an RHIO. Okay? Like I said, there are challenges to an RHIO. Basically, you know, especially when you're dealing with competing competitors in terms of healthcare type facilities, sharing of information, making sure they don't, other organizations don't get any of their quote unquote competitive secrets, security issues. When all of these different places are putting information into a pot per se, you got to look at security and privacy and how all this is going to work. The other thing about this, it really flows into when we were a little earlier, we were talking about the different things that the federal government and their interests with that National Office of the National Coordinator through President Bush, when they're looking at that goal of the health information exchange or helping to improve care and reduce medical costs, using these types of mechanisms like the HIE, Health Information Exchanges, as well as the American Recovery and Reinvestment Act that I was talking about a little earlier. They provide financial incentives for different eligible providers to adopt the electronic health record. We also, they use meaningful use criteria in which to do that. to figure out who will receive those financial incentives. And part of that meaningful use criteria is health information exchange. That's one of the criteria. So it's advancing that health information exchange. That RHIO flows right into that because they also pushing health information exchange with the use of RHIOs. Also, you got new privacy regulations that are coming from your American Recovery and Reinvestment Act that work alongside your HIPAA. And it also provides new workforce opportunities. Along with this push for adoption of EHR, there are new roles, HIM roles that HIM professionals can take on that's in line with the electronic health records and all this technology. Now, your chapter also talk about these health record systems and some of the components of those electronic health record systems. Basically, the goal of those is to collect, analyze, process, display, and retrieve healthcare data and information. So when we're talking about data and information, data is basically raw facts, just something like that. So I can just say 5, number 5, that is data. It's just a fact, 5. It doesn't really have any meaning. Once we can apply meaning to data, then it becomes information. And so when we're looking at that data is pretty much organized in a hierarchy where your smallest piece of data, we call that a character. So character is the smallest piece of data. So like a letter, the letter A, right? Or a number, like the number 5. That's a character. That's the smallest piece of data. Now, a group of characters forms a field. All right? Then a collection of fields or group of fields forms a record. A group of records makes what we call a file. All right? So that's how that works. So it goes from a character to a field to a record to a file. It's almost like when you think about AMP in your body, you know, your tissues, and then it makes an organ, and a group of organs make a system, that kind of thing. So it's a hierarchy. You have an example here, which is also in your book. This is actually figure 5.3 on page 114, showing a patient registration screen. And your book brings out that area where it says account number, your medical record number. If you're looking in your book, this is what we refer to as a field. And then just your individual numbers of your account number there, like the 1, the 0, the 6, this is what we call a character. All right? And if this is for one specific person, that whole thing, you have a record. Right? So it just goes up. So you got characters to a field, then a record, and then you might have a group or something where that would be what we call a file. Now, just like we talked about in our paper records, about all records have administrative and clinical information. The same thing goes for your electronic health records. There is clinical and administrative applications that make up an electronic health record. Your registration, admission, discharge, transport system, or your RADT, basically is like a centralized database that collects all their information. It has on their admissions and discharges and things like that. I think you have, let me see, do you have an example? Where figure 5.4 is more or less a patient registration screen, and figure 5.3. But it collects all the patient's demographic information, insurance information, and all that kind of stuff. And it actually takes like the place of a master patient index. A lot of times it serves both purposes. you will notice you also have, and that will be considered like administrative application. That would be an example of administrative application. Patient scheduling, registration, your business financial functions, those would be your administrative applications. Then you also have clinical applications, like a patient monitoring system, one that maybe monitors your vital signs for the patient. You got pharmacy applications. Of course, they're going to help with the processing of the medications for the patient. You got laboratory applications, laboratory orders, test results, those kind of things, reports on those. Radiology applications, same thing, but in the radiology department. You got nursing applications, all those applications that assist them in doing their nursing job. And then you have your medical documentation applications, like your charting functions, your progress notes, and those things. You actually have some pictures of those as well. So here's a patient registration screen here. That's in your book there. That's that figure 5.4. And here's an example of a clinical information application. This is your figure 5.5. This is your progress note. And then here's a patient intake screen exam. That's figure 5.6 in your book on page 116. Both of those are clinical applications. This serves as the end of the presentation. I hope you enjoyed it.